Good evening and a warm welcome to everyone who has joined us in this Gyan Pravah podcast series, episode 7. This is a project of our visionary president, Dr. Sunita Tandulwadkar. I, Geeta Ramamurthy Pal, chairperson of the Genetics and Fetal Medicine Committee, Fogsi, welcomes you to this podcast on fetal medicine, changing paradigm, for which we have none other than the father of fetal medicine, a pioneer in fetal medicine in India, Professor Suresh Seshadri. Thank you, sir, for accepting our invite and welcome to this podcast.
Thank you. Thank you for inviting me.
Before we start, may I have the privilege and honor to invite and introduce our dear president, a dynamic president, Dr. Sunita Tandulwadkar, Foxy for this year 2025. Dr. Sunita Tandulwadkar is a very renowned infertility specialist, endoscopic surgeon, and she heads the IVF unit and Peds and Gynae unit at the Ruby Hall Clinic, Pune. She's also the founder and medical director of the Solo Clinic IVF, which is a center of excellence in infertility, and also the co-founder and medical director of a stem cell research and application center, Foxy. She has this extraordinary achievement of delivering the India's first stem cell baby, first at the age of 45. She heads many organizations. She's currently the president Foxy. She's the president-elect of ISAR, has been the past president of IAGE, and is also the founder president of the Society of Ovarian Rejuvenation 2023. Madam has many awards to her credit, and to mention a few is the Bharat Gaurav Puraskar, Glory of India Award, and has also received a letter of appreciation from the President of India. She has authored many books and has many publications, but overall, thank you, Madam, for giving us all chairperson unique opportunity and platform to host this podcast. May I please request you to deliver the welcome address to the podcast? Thank you.
Thank you, Sita. Thank you for your kind words. Friends, my Foxians, and those who are watching this live podcast, welcome. Every day, 8 p.m., this Gyan Pravah series come to your doorstep. I have brilliant 30 committee chairperson, and every day one committee chairperson come with a brilliant idea of having either academician, politician, social, anyone, but giving us the best of a knowledge, may it be in an academic or non-academic field. Today, Dr. Sita has come with Professor Suresh, and I'm very sure this is going to be one of the most academic podcast you can ever have it. This podcast link, what you are getting, is the same link every day, only the chairperson and the speaker or the faculty is different. So don't search for the link here and there. The same link you will have every night at 8 p.m. Sita, I wish you all the best. And Professor Suresh, it is the way we work is I will be just here to welcome you, to give you greetings on behalf of Foxy, and then Sita and you will be in the frame, and I will log in from the delegate link.
Thank you. Thank you very much. Thank you
Thank
for inviting me.
Thank you for being here.
Thank
Yes,
you.
Sita, you
Thank
wish to introduce, sir?
Yes, yes.
Support team, I was hearing a little background noise when Sita is speaking.
Yeah.
Just check out. Yeah.
Thank you, Madam, once again for this opportunity. And now it's my proud privilege and honor to introduce none other than Professor Suresh Seshadri, who's a teacher of teachers. I won't say he needs no introduction because there's a long introduction list, and please, sir, let me have this opportunity to introduce you. Professor Suresh Seshadri is the director of Mediscan Systems Diagnostic Ultrasound, Fetal Medicine and Training Center in Chennai, Tamil Nadu, India. The center was started in 1982 and is now a tertiary reference center for prenatal diagnosis and fetal therapy. He's a professor of practice at the Department of Medical Science, IIT, and has trained in fetoscopic surgery in Necker Hospital, Paris, and he has performed over 25,000 diagnostic and therapeutic procedures. His special interests include fetal interventions, teaching ultrasound and fetal medicine, device development for use in ultrasound training, developing fetal databases for ultrasound reporting, including birth defects registry and artificial intelligence. Sir is a professor of practice at the Department of Medical Sciences, IIT Madras, and is also a visiting professor in perinatology at the Sri Ramchandra Institute of Higher Education and Research in Chennai and the PSG Institute of Higher Education, Coimbatore. Sir is actively working for the standardization of obstetric ultrasound through implementation of the ISOOC, that is the International Society of Ultrasound and Obs and Gynae, for the basic training across the country. And in September 2024, he has been appointed as the trustee for this ISOOC. Congratulations, sir. So has also been conferred FRCOG by the Royal College of Obs and Gynae, awarded the Doctor of Science by the MGR, Dr. MGR Medical University, and the Champion of Chennai Award by the KSA Trust. So is also the CEO of the Voluntary Health Services Multi-Speciality Hospital, which is a public charity where he actively strives to provide affordable health care to the community. Sir is also a trustee of the Fetal Care Research Foundation, which helps the underprivileged and provides preventive, supportive, and curative care for birth defects and rare disorders. Sir strongly believes that the best of medical technology should be available for the common man. And in this pursuit, he has trained countless doctors across the country and other countries in obstetric ultrasound and fetal medicine. He has over 100 publications and has authored many books in fetal medicine. He also has other interests like nature and wildlife photography and amateur radio. So thank you, sir, for being the first podcast speaker for my committee, our committee, Fogsi, and we can start this podcast. Thank you so much.
Thank you very much for inviting me, Dr. Sita. And thanks to President Dr. Sunita for inviting me to this podcast. I think it's a brilliant idea of sharing information. We are all used to listening to lectures, but having a dialogue like this actually makes a huge difference because here thoughts are exchanged. And when thoughts are exchanged, the flow actually leads to one thought of the other. And overall, we get a larger picture of what's happening in a particular area. So thank you. I'm very excited about going through the podcast.
So are we, sir. Thank you so much. You're muted.
Thank you, sir. And that's why the name is Pravaha, the flow of knowledge between the two great visionaries, I should say. Thank you.
Thank you once again.
Bye.
Bye-bye. So, sir, as a pioneer of in fetal medicine in India, when you started off, I'm sure you might have faced many challenges when you started this concept or introduced this concept in India. We would like to know, how did you circumvent these challenges and come this far in this area of fetal medicine?
Okay, so first of all,
medicine, sir.
I need to do a little bit of correction here, as when you said the word pioneer in fetal medicine. So let me take you back to the 1980s, where when I decided to change my career course from being a surgeon to doing ultrasound. It was a very significant career change, and it was done out of the sheer fact that I thought this as an opportunity and found that ultrasound was one modality which was not available in my area, and tried to read about it and tried to find somebody who will teach me how to do ultrasound. And so the whole journey started off like that. And that took me to Mumbai for the first time in my life. And then there I found a person who said he's ready to teach me on only one condition. And this is the most profound message I had in my life, that if you want to do ultrasound, you have to do it as a full-time job. You have to give up your surgery and do ultrasound full-time. If you agree to that suggestion, then I will train you. This is what my mentor, Dr. Hemant Shah, told me. It took me 2 days to decide. And after that, I said, okay, let me do full time. Having committed to full time, I said, let me go through it. And the whole thing, remember at that time, was only obstetric scans. There was no word called fetal medicine at the time.
Absolutely.
And obstetric scan, most of the scans were in the third trimester, and they were going to deliver the baby by cesarean section in the next few days. They'll go and say, rule out anomalies, because if it was an abnormal baby, then we won't do a cesarean section. And that's all it was. And when the biparietal diameter was 9.4, then the baby was fit to be delivered. These were the benchmarks at the time. Till we realized all these numbers actually made it was. We had a baby who was full term, and the BPD was only 8.9 centimeters. And when we wrote the report, the doctor said, "I won't deliver now." She's 39 weeks and 4 days, and she said, "I will not deliver now. I'll wait for another 2 weeks till the BPD becomes 9.4." And then that baby became an IUFD. Okay, remember this. So it came as a rude shock to me, and I felt that the giving a number was not the right thing to do. And at that time, very little information was available because there was no internet. There were no books which are freely available at that time, because all the real-time ultrasound had come into India only in the year 1982. The first real-time ultrasound came in 1982. And then, so the change between static scan and real-time, the start of fetal medicine, I should say, when real-time actually started, where we could look at, but we didn't use the term fetal medicine at the time.
True.
But as we went along, one instance changed the entire thing. For example, my first abnormality which I diagnosed was a hydronephrosis in a 28-year-old fetus. So I was very excited about making the diagnosis. So I called the mother and said, I sat with her and said, I made a diagnosis. It looks like there's a block in the kidney, it's hydronephrosis. And then she smiled at me. And I said, here I am giving an abnormality report. And the mother is smiling back at me. She said, thank you very much, doctor. What should I do now? And that hit me like a bolt. Because I had no answer to that question. I knew how to make a diagnosis, but I did not know what was the implication of this diagnosis. And then I quietly told her, please take this report to your obstetrician. She will sort it out for you. Right? And then 1 hour later, I get a call from the obstetrician saying, you give me a report. What am I supposed to do with it? So I said, let me check with my mentor. I called him up and he gave me a very important thing. He said, wait till the baby delivers. Now, this was fetal medicine at that time. You make a diagnosis and you have to wait till the baby that delivers. So the question now is, within a short time, within a few years, the concept of screening for Down syndrome came up. And that time it was a triple screening. And that really was the time when we started exploring that could we predict some things in the fetus. So by this time, after 3-4 years, the second trimester targeted scan has become an important thing, but till the acceptance was very low. And Down syndrome screening, believe me, once I initiated it, there were very, very, very few takers. There were obstetricians who told me, my patients will not deliver a baby with Down syndrome, right? And in a whole year, there were about 10 people who were referred for first trimester, triple screening. And then one day, one of the senior obstetricians, she delivered a baby with Down syndrome. And she called me and said, from tomorrow, I'll start sending patients for screening. So the trigger, as you say, the challenge we see here is actually understanding the concept that we can actually do more for the fetus. We have to start looking at the fetus a little bit more. And again, that time you see, all we did was fetal cardiac activity present. There was not even imaging the four-chamber view or outflow tract. So cardiac anomalies diagnosis was a no-no. So anencephaly we could find out. Okay, large abdominal wall defect we could find out, and beyond that, very little, because even spina bifida were being missed in a very significant way. And ventriculomegaly, it was hydrocephalus. It was called as hydrocephalus at the time, and so when Down syndrome screening came, then slowly the concept started becoming a little better. And the challenge again here was what do we mean by the word fetal medicine anyway? So everybody was sending for scans. It was an ultrasound scan. The concept that something more had to be done, and the word fetal medicine had to be thing. You needed a 360-degree approach to the fetus. And the 360-degree approach was you make a diagnosis, you provide a solution, you move from imaging specialist to a solution provider. And providing the solution was actually, in other words, that after diagnosing intrauterine growth restriction, there was no Doppler at the time. When should the baby be delivered? Is the environment hostile? So the only thing we had was Leica, biophysical activity, but there was no Doppler at that time, isn't it? So, but there was an opportunity here that we could identify a small baby, and when the baby was not having good amount of Leica, it was considered as an index of chronic hypoxia. So we could make a meaning out of less Leica means hypoxia. And so this was one of the things that happened. So like this, step by step, you identify a problem, you identify a finding. From the finding, how do you extrapolate it into a clinical information? And how can the obstetrician apply it to the patient to give better prenatal care? So the road was not very smooth, but
Yeah, I'm sure. Because I think, right, as rightly you said, it's only when the obstetrician faces that situation in their practice do they realize that something needs to be done. I think when you started off the Down syndrome screening, everybody used to say the West are doing it, you don't need to do it, those sort of things. But when it happens to you, when you deliver a child, when you have an IUD, only then you realize the importance of screening and detecting these anomalies. I'm sure you had faced a lot of challenges, sir. But over the years, how do you think fetal medicine has evolved in India over the decades since the time?
today I think we have gone very, very far ahead. We have gone and we can feel proud of that India has moved ahead very significantly. But let me take you back at that time when we how kind of. So the question was, you needed diagnosis, okay, and when you needed diagnosis, it was not enough to do only an ultrasound based diagnosis. We needed, so they said increased nuchal fold thickness in the second trimester is a marker for Down syndrome. So soft markers for Down syndrome actually evolved, and we started looking for soft markers. And when these soft markers evolved, the next step is, what if I find soft markers? What should I do? Then you have to put a needle and do an amniocentesis and send it for culture. But then there were very, very few genetic labs in the country. I still remember one of my earliest cases where I put a needle and took the fluid. The husband was made to wait. We timed it such that there was a flight to Mumbai he will catch, take the fluid in the hand, go to Mumbai, deliver it in the lab, and then he will come back and they will send the report by post for many years. So this was fetal medicine at that time. But so the question now was, there was an infrastructure that's needed, which means if you want to do fetal medicine, there needs to be genetic support services. And so we had to identify somebody who could do the cultures. And interestingly, the first lab culture that was set up was not for amniocentesis, but was for fetal blood sampling. And you know, it is a nightmare to do fetal blood sampling because you had to put a needle into the umbilical cord, and it was a very, very difficult task. But because that was the only fetal sample that could be cultured, because lymphocyte cultures were available, I started off by doing fetal blood sampling. And amniocentesis, in fact, was the last thing I did. The second was chorion villus sampling, and third was amniocentesis.
That's interesting, sir.
very, very, very unusual. But over a period of time, once we had the genetic lab support, things were much more easier. Now, by this time, I think in India, the excitement had already started. Michael Harrison had written the book, The Unborn Patient. So when the fetus was actually christened as a patient at the time. So the whole world caught up to that word called unborn patient. And then the fetus as a patient was one of the early conferences that took place, where they started discussing more about not beyond imaging, that fetus as a patient, where we should treat the fetus. Then they talked about fetal rights, fetal autonomy, and these kind of things happened, and that translated. So what if you have to learn something, you have to travel abroad to some conference like this, sit down and listen to some other meeting, then come back and try to put it to practice. So this was how, and over a period of time, the training model in India started. And more people started training. Many people got excited, and I think quickly it spread all over India. Today, I think we have a fair spread of fetal medicine services across the country.
Yes, sir. I think it has come a long way from where we knew what was nobody knew the concept of fetal medicine. For that, we have really come a long way. But sir, having said that, there are still some gaps in our country, especially with the infrastructure. So, how would you address this problem in our country? I mean, we are seeing, the extremes of both. So what is your opinion on why these gaps are
So,
there?
see, one thing we have to understand is uh, fetal medicine infrastructure. So let us decide what is fetal medicine infrastructure. Fetal medicine infrastructure largely revolves around the skill of the individual. Okay, but that is, there should be a person who's very well trained in imaging decision making. The decision making component is probably more difficult than and counseling the patient. So translation of information to, I'll give you a very, very simple example. Just yesterday, we had a patient who had a scan at 21 weeks. They had reported fetus was structurally normal. They had reported hypoplastic nasal bone and hypoplastic nasal bone. And in that, it is clearly written that to do amniocentesis to exclude trisomy 21. Okay. Now, the patient comes back to the same doctor at 31 weeks. Nothing was done in between. And hypoplastic, so the doctor has asked, why have you not done? And the patient said, well, you told me my baby was normal and you didn't tell me anything more. So what had happened was there was a communication gap there was no insistence on the fact that the amniocentesis need to be done. Then this patient goes to a pediatrician referred who's in a genetic clinic, and they order NIPT. Now she's 32 weeks. They order NIPT. Can you believe that? Now, when you order NIPT, what is the reason? Because if you do amniocentesis, they counseled her there's a risk of abortion. Now, this case illustrates the gaps in India, right? What is the gap in India? Knowledge gap. That knowledge gap and training and proper methodology of standardized process of counseling for various, even the common problems. The second thing is the laboratory infrastructure which you require. Now we can say proudly that genetic labs are available across the country. So that one gap is taking place. But the the next level. So the next level is prenatal diagnosis is one level, fetal therapy is the next level. Now, fetal therapy, I strongly believe a very small portion of the entire obstetric scan group is what requires fetal therapy. Very, very small portion. That is, in a whole year, if you're doing, let's say, 1,000 scans a month, then your opportunity for fetal therapy will be maybe two or three patients, right? So for this, what is exactly required is we need to have regional centers where good infrastructure. Supposing I want to invest in doing uh, a laser, for example, or a complicated twin management. So I have to spend about 30 to 40 lakhs putting up the equipment. And if I'm going to use that equipment for only three patients in a year, the cost of care goes up. So I strongly feel that there should be common centers with infrastructure facilities where anyone can go and perform their cases and come off. So like regional centers, right? But we know that this is very difficult to establish as far as the private sector is concerned. But if the government puts its wish, puts its mind to it, then this is eminently possible in the government sector. We'll talk about it when we talk about the government services.
Yeah, sir. Thank you, sir. But at the same time, when we talk about, this disparity, a lot of centers don't get even basic and consistent fetal care. And there is a lot of, as you said rightly, there are cities where they have the best of fetal care, especially if they are come to your center. But at the same time, basic centers don't get even the basic ultrasound. So how do you think we can address this problem, and how can we ensure that this parity is maintained, in your
This is
opinion?
an extremely important problem that needs to be addressed for two reasons. One reason is the public have become very, very aware, at least in the private sector. The public have become very aware, and their expectations from ultrasound is extremely high, right? Now, if quality ultrasound is not provided, it leads to litigations. Okay, so on one side we are talking of fetal medicine, the other side we are talking of uh, the gap between expectations of the patient and what can be provided. Now, how can we address this? Point number one is every person must know how to draw their Lakshman Rekha. This line which you draw saying that this is my level of expertise. Now, beyond this, I need to seek help. Okay. It's not a question of patient going away from me or I will not get back the patient. There's no harm. Just get additional help. The patient will be grateful to you. I'll come back to you because if I go to this doctor, they know exactly what to do and then they will do what is best for me. So this is something which you need to do. Secondly, how does one learn? How does one learn? The only way somebody can learn, because you can go and get training. You can go 6 month training, you can have 1 year training, you can have 3 months training, you can do all the training. But when you come back and start doing on your own, then you become wholly responsible for it. Now, all of us as a human being, when I do a scan, I always try to do my best for the patient. I will not unnecessarily, I will not shortchange the patient. I'll say I'm doing my best for the patient and say, in my capacity, I feel I have already done the best. What I'm doing is always right. Because if I know what I'm doing is wrong, then I won't commit that mistake, isn't it? So I will always think what I'm doing is right. But how, in artificial intelligence parlance, there's a word called ground truth. They're called ground truth. So in every case, there is a ground truth. Now we need to understand the ground truth. And that's the only way you can improve the quality over a period of time. Now, what do you mean by ground truth? Luckily for us, pregnancy is the only condition in, in medicine which has a beginning and will always have an end, right? There will be a beginning, there will be an end. And the end is where you can visually see what is the product. That's the baby, right? So anytime the baby is delivered, if you have found an abnormality, the pregnancy is terminated, the final diagnosis has to be got back into the system. And I feel if you want to improve the quality of fetal medicine, every obstetrician who is referring cases to different specialists will have to give feedback to the same person who did the scan, whether right or wrong, no problem. But they have to go and say, they have to go and tell that there is a, for example, a few days ago, there was a baby which was born, and the baby has an imperforate anus. She had come for 2 scans in the pregnancy. Now, we always have a policy of looking at the perianal muscular complex. And we said, okay, we did not find this, we did not identify this abnormality. So you go back on your image and identify, yes, the PAMC was there. And then we found a reason why the PAMC was present. It was low anorectal anomaly. The anal sphincter was still there, but it was not open. Right? So this is something we get our thing into, and it tells me 2 things. One, yes, you have done your job correctly. Second, next time when I say I'll have to see any other methods by which I will not miss this condition again. So this is the next level of improvement. Every individual doctor must go through this, and that's the only way you can progress. So communication between the clinician who's handling the patient and the person who's imaging, you provide the information. You're not providing information, but you're actually contributing to increase of knowledge and the quality.
True, sir. Very
The
true.
only answer.
So you did mention about the role of government. So how do you think the government policies can help in, improving our access? You were talking about regional centers which the government can help.
So government policy. First of all, the government must consider this as on their priority list. Okay. If you take, there are very few hospitals across, government hospitals across the country where they have established a department of fetal medicine and given all the infrastructure necessary to run the department. Right. For in our country, if you take, for example, AIMS was the forerunner. I remember Dr. Kamal Bakshi was there. I used to go and watch her do procedure. That's why when I said pioneer, I was a little concerned because she had already done enormous amount of work and intrauterine transfusions, fetal skin biopsies, something which she was doing already that time. So in the private sector, yes, of course, in the public sector. So there are very few hospitals. So government must actually give more care because what they are investing in, they should know they are investing in the future generation. To get a less hypoxic baby out, that baby's future is going to be good, and that citizen is going to be a better citizen than somebody with having a disability. So preventing disabilities should be a responsibility of the government, especially people who seek care in the government sector. The more you invest, the better it will be. Now, otherwise, policy means that every OBGYN department, they should have a fetal medicine department. And what you do is if an obstetrician likes to take fetal medicine as their specialty, then what they will say is you'll also have to do 15 night duties. You'll have to go to the theater and come spend 5 minutes. You are allowed to spend 1 hour in the fetal medicine department. That's not work. Fetal medicine is a specialty which needs full-time people. So they have to designate full-time. Of course, you can do delivery. The person doing can also do deliveries, no problem at all. But the proportion, the larger amount of time you spend in the fetus, you get more skills and you get better outcome from that. So that balance has to be maintained. This is all the government needs to invest in because we have the population and uh, we have it in us to do it.
You have the volumes of patients as well, so
Yeah.
there's no dearth of that. Yes, sir, true, very true. I mean, it becomes difficult to, when you start off as an obstetrician, it may be difficult to completely leave it. But as you rightly said, if you don't dedicate yourself to that, then it becomes difficult to become an expertise there. But sir, in terms of fetal therapies in India, and we are having cutting edge fetal therapies, how accessible are they to to our general population? Because we are in coming up in a big way in providing, especially at your center as well. but in accessibility, what is your
Right. So here, when you
especially
say,
compared to the global scenario?
yeah, yeah. So first of all, let's talk about cutting edge fetal therapy. What do we mean by cutting edge fetal therapy? For me, the most common fetal therapy, most successful fetal therapy, as we all know, is intrauterine transfusion for RH disease. Highest rate of success across the country now. You can get it. Patient need not travel too far to get an intrauterine transfusion. That's a very big step because that is a low hanging fruit. That's the most common problem which you're going to see. Now, if you look at any other form of fetal therapy, like for example, putting shunts in or to the thoracoamniotic shunt or vesicoamniotic shunt, whatever it may be, the outcomes, for example, vesicoamniotic shunt. Still, the world is grappling whether shunt should be done or should not be done, when it should be done. So, if you give, if you're able to do a therapy which is most commonly required, you have made a big milestone, big milestone forward in that already, right? The second thing is when I say accessible, okay, when I say accessible means, do you mean accessibility is reaching within 10 minutes? I should be able to reach a fetal therapy center, or therapy center may be 50 kilometers away, but still I have the wherewithal to go and access that facility. So then secondly, what happens? Largely you realize that fetal therapy centers are in the private sector and the government patients are not having access to that. Now here is where the responsibility of the medical fraternity comes. And it's not difficult in India. Why I'll say? Because we have proved it that any patient who wants fetal therapy in our center will get it irrespective of whether they can pay or they cannot pay. There is there is no limit to this. Okay, anyone can have it, whether it is laser surgery or an intrauterine transfusion will get subsidy. How? Because today in India, the government has made a wonderful thing called corporate social responsibility. Now, this corporate social responsibility, all that you need is create a vehicle for this getting funds from corporate social responsibility. And there are many people willing to provide the funds you require for your expenditure. So making it accessible is only the effort we put in. If you have the expertise, you can make it accessible. Not difficult at all. But it does require some effort put in. And I think in every state, every region, somebody should be champion this cause and maybe start a small charity, a foundation or something like that, and engage people in that. It will give you immense dividends. Dividends
Both
are
ways.
in both ways. It helps both ways. And remember, that child from the poor family is going to be the breadwinner of the family later on,
Mm.
right? You are actually you are ushering in a new generation where you are providing life to an individual, that's opportunity, and that family will be ever grateful to you for that. So we should not allow any fetus which requires fetal therapy or even prenatal diagnosis to go away because they don't have money. That's our responsibility. That's what accessibility means in my language.
Yes, no, that is a big part of accessibility. And it's so heartening and gratifying to see these patients when they come back with their child, especially these intrauterine transfusions, which
Absolutely.
might have given them a very bad picture initially, but later on when it finally succeeded, it's very, very gratifying. So
Absolutely.
sir, it has, I mean, fetal medicine now has become a very coveted specialty. Everybody is wanting to do it now. A lot of people are taking interest in it, and especially with teachers like you, with so many other training centers we have in India, it has come a long way. But where do you see India next 10 years? I mean, what is the future of fetal medicine holds for India, and what is the future ahead?
The future in this field, sky is the limit. Okay. Why I'm saying this, I'll tell you. because technologically the research is happening in various areas. Now, it's simple example. We never imagined that you could just draw the mother's blood and take out the fetal DNA from that and do a prediction there. Correct? And they're saying now you take it from there, it also predicts mother's malignancy. I mean, kind of that kind of a thing we are going to. So when you talk about one is firmly establishing what are accepted therapies with where evidence-based accepted therapies which can be given consistently across the board to anyone who requires it. That it's a big milestone. The second one is therapies which are exploratory in nature. There are anecdotal because evidence has still not been created. And some therapy, for example, even for example, in India, we have not made much headway on fetal for diaphragmatic hernia, not as much as we would like to do. Second thing is open surgery for spina bifida, open fetal surgery. So we have not made much headway in this. There are reasons for that also. If you say why we are not doing spina bifida surgery when so many other countries are doing, is because if we identify our law allows for liberal termination of pregnancy. So rather, you would rather terminate than have a baby with a handicap. And there are countries where termination is not allowed. And those cases, they want to make the best out of the situation. So if you to look at patients' acceptability of a procedure, so that is something which is, so technically you might be, you can do it. It's available elsewhere. We don't need to feel distressed that we are not doing it here, right? Because it's one-off case which we do. And if you do, one of the important, either fetoscopic surgery or open fetal surgery, a center must do a certain number in a year to keep the skill sets going. The outcomes will be better only then. So we don't need to feel ashamed that we are not doing this. But when the sufficient volume builds up, then at the time provided we can provide that care that is required. But let's look at from the other side, from the genetic side. Okay. Now, increasingly, genetic diagnoses are made earlier and earlier. In the first trimester, you can make a lot of genetic diagnosis. And if you already know, for example, hemophilia or alpha thalassemia, something like that, you know already. Now, what is happening is possibility of gene editing and putting it inside. That's already come in the world. It's still not available entirely, but people have done in utero stem cell therapy for osteogenesis imperfecta. There are a few babies which are going around who have done that. So those are areas which are potentially for exploration, which may be available. And I think your ultrasound quality, machine quality has also improved significantly. So our diagnostic capability has become better genetics and counseling facilities. I see more and more people getting into the field of genetics for fetal medicine. And the therapy part is something where there are common therapies which will be continuously providing, and there'll be rare therapies which some centers will start exploring that area because of specific expertise or collaborative effort from various other parts of the world.
Yes, sir. So, I mean, there are ethical issues, isn't it? Especially in our population where they cater to, where they're going to be able to bring up, as you said, a child with disability or not.
Exactly.
So those sort of things come into picture when even if we are able to offer them, it's up to the couple and the family whether they're really able to go ahead and bring up that child, because that itself involves a lot of.
See, the important thing to know is once you do fetal therapy is only a temporary measure. There's a lot more things that needs to be done after the baby is born. So neonatal care has to be at its peak. Neonatal care has to be at its peak. More and more younger babies will be born. Preterm babies will be born. So that optimizing that care and accessibility to that service is very essential for fetal therapy. You can do a fantastic laser, but 2 weeks later, if she goes into preterm labor, and there is nobody to take care of that 26-weeker,
Center where there is
so I think when we are talking of fetal therapy infrastructure, you cannot but include the need for very strong neonatal support. And that's the multidisciplinary team which needs to be there. So that's where we think we need to really buck up, because neonatal care much better than before, but level 2 and level 3 care centers are relatively fewer.
Yes, that's true. I mean, some centers are able to look after even 1 kilo babies, but there are centers, even now when we hear in this day and age that 2.3 kilos or 2.4 kilos they have,
Right,
been. So that is the important bit, very rightly said, sir.
right.
So in terms of, for our young specialists who are learning to learn fetal medicine and obstetricians as well, first, what would be your advice to the, you have said partly some about training, but generally, what would be your advice, sir, to the budding fetal medicine specialists in India and the obstetricians as well, sir?
So can I be very candid about this? Because I'll tell you what. Uh, Supposing uh, a young doctor decides to become a fetal medicine specialist, spend 3 years of her time in training. Okay, either India or abroad, somewhere it is. She spends a lot of time focusing on that, getting well trained and certified at the end of the day, right? Then she comes back into her own environment, unless and until the her colleagues who are there around practicing recognize that here's a person who is now specialized in this. Let me take her services or his services for my patients. And that increasingly is an uphill task. So there is a pie, and everyone wants a cut of the pie. And how is it that you are going to fit in that environment and prove yourself that yes, you can do high things? What will happen is, in a center, for example, there's a very good fetal medicine specialist I know of, but once a fetus requires some therapeutic measure, the patient will travel some 100 kilometers away. Correct? Because faith has to be built in, right? So, as a young specialist, you need to be aware that you are in this game in the long run and not in the short time. Recognition will come over a period of time. How recognition will come? When you start solving difficult problems. Then people recognize your talent of solving difficult problems. Then and only then you can sort of move up the ladder. So it does take a little time. You need extraordinary amount of patience for this, because I'll also tell you this. You get one rare case, okay, where you made a fantastic diagnosis. Immediately your name will become viral, right? But you've done 50 cases, all excellent work done, that will not get noticed. It will get noticed when you are providing information on a very challenging case. So that's why we see now many people doing excellent 3D ultrasound and then sharing in the WhatsApp groups that how they have taken a superb picture of the outflow tracks or whatever in a silhouette mode using all the technologies available. Then wow! So that's a wow factor, and the wow factor brings respect. Okay, and people go up the ladder, earning respect along the way. It's not by just being there. You learn there. Any time you strive for earning the respect of your colleagues, nothing else. Rest everything will fall into place, right? It doesn't come automatically. It takes a lot of effort, because after all, you and me are at the same level, isn't it? So that, because at that time you slowly build up the rapport, and then work extremely hard. That is, if you identify something, doing references, being up to date about what is happening, what should be done, never be dogmatic about anything. Don't take anything for granted. That's the problem. Because, for example, CMV infection, right? Supposing CMV infection, we know all the signs of fetal infection which is there. And here's the patient who comes a day, is a 14-week fetus or 16-week fetus with a mild pericardial effusion or mild pleural effusion. So what to test? So you test, okay, you do karyotype, you do microarray. Okay, don't do karyotype, but do microarray. But you leave out the fact that you need to look for infection. And finally, what happens? This baby, you do all the tests, it turns out to be a CMV infection. Correct? So, what are the manifestations? So, there's one baby which just had a cardiac dysfunction, nothing else. Perfectly normal baby, just little bit of cardiac dysfunction was there when the tricuspid valve, mitral valve showed an altered pattern. Everybody we were perplexed. He said, go and do these tests. Turned out to be CMV infection. And then you go into the literature, there's somebody who's published a whole series on that. That if you see a cardiac dysfunction pattern and you have a cardiac dysfunction like this, you look for CMV.
That was the only finding.
That was the only finding, nothing else. So this is what fetal medicine is all about. Fetal medicine is not about doing fetal surgery. It's about understanding the fetus. It's about rising to the needs of the fetus. And you're doing, so I keep telling, we stopped doing ultrasound many, many years ago. 1987, we stopped doing ultrasound. What we do now is we are doing a clinical examination of the fetus.
Oh, that's a nice stuff.
We do only a clinical examination of the fetus. For me, the probe is like a stethoscope, which I use to hear the heart sound. I'm not able to see the heart, so I'm just listening to the heart. So here I'm not able to see the fetus. I'm listening to the fetus by Doppler, and I'm also seeing the fetus by using some method. So I don't call this as an imaging modality at all. It is a tool for clinical examination of the fetus. You transform your thought from imaging to clinical examination of the fetus, then you will become the fetal medicine specialist which you want to be.
That's fantastic, sir. That's a new approach altogether. Well, ultrasound has become the stethoscope for obs and gynae, isn't it? No, people no longer use the so, but a different perspective to fetal medicine is using
the government needs to liberalize this. Point of care ultrasound needs to be freely available. The more restrictions you place on ultrasound, the more disasters that are going to happen. And saying you cannot do, you cannot do, all kinds of things has to go. We need a system where a woman has free access to good quality ultrasound.
Right. Thank you so much for that. And what about the obstetricians? What would your advice be as a fetal medicine specialist?
Obstetrician.
A lot of audience are watching.
My survival depends on obstetricians. Okay, so and that was in a lighter way. What's important is the obstetricians also should be abreast of what kind of ultrasound, how to react to an ultrasound report, right? Because ultrasound report is a translation of the thought process of an individual who spent half an hour or 45 minutes on a patient, and he puts it in 1 page or 1.5 pages. Now you must be able to read the mind of the dog. Why have they put this here? Why is it called as fifth centile? Why is it come like this? So how does it going to imply? What implications going to be in the fetus? So what they would, in case they're not able to match their clinical expectation and the report, immediately call and have a dialogue. The dialogue between the obstetrician and the fetal medicine specialist will go a long way in improving care. That's all they need to do, right? And provide feedback. Right or wrong, doesn't matter.
Yeah.
Feedback is the only thing that will strengthen. They will get more quality reports over a period of time by giving this feedback.
True, very true, sir. I think it's important that, as everybody says, we all speak the same language so that the patient doesn't get confused at the end and gets different messages from different people. Because
Yeah.
if one person telling one thing, there are 10 other people waiting to tell them to terminate pregnancy, isn't it, sir?
Yes.
So, yeah. So I think we're nearing the end of the session, sir. So, but
Yes.
one last message from you before we end. And again, thank you once again for being here. But one last message from you, sir, before.
So one last message for me is I'm telling everyone who's in this field, it's time to fall in love. Okay? It's
This
time to,
month of February. So.
yes, month of February, you take a vow on February 14th, you will fall in love with the fetus. Okay. You fall deeply in love with the fetus. And whenever you love somebody, you will do anything for that person,
Yeah.
irrespective of what it is. So start uh, admiring the fetus. Every baby would come is joy to be admired, and ensure you work for saving that fetus. The word termination should be the last on your agenda. If you're a fetal medicine specialist, you're here to save lives. You're not here to tell terminate, terminate, and terminate. Is there a possibility this child can have a good life? Because we are not the predictors whether this child will become the prime minister of our country later on or the president of our country later on. The opportunities are huge and they should be given a chance. Give life a chance. That's all I will say.
Great, sir. And I think we learned a new concept again from you, sir, about clinical examination of the fetus. That's so wonderful. From tomorrow onwards, I think whenever we all scan, we will do head-to-toe clinical examination of the fetus.
Exactly.
Thank you once again, sir. I know you
Thank
have a
you.
flight to catch. So, a profound thanks from Foxy, from Dr. Sunita Tandulwadkar, and all of us for being here and giving us insights into a beautiful concept of medicine and the field of fetal medicine. Thank you once again, sir.
Thank you for having me and to the great discussion. Thank you very much. Yeah. Bye.